Hello, everybody. I'm Dr. Avni Skandhan, and I'm going to be talking about a very important topic, radiation protection. It is important not just from the perspective of our exams, it is a very important topic in the exams too, but it is also important because radiation protection is something that we deal with in our day-to-day practice. It is something that we have to be aware of if we have to practice our specialty properly, and at the same time, if we have to guide our subordinates, our staff, and also to be able to guide and help out the queries of the patients or the bystanders who are always filled with queries. So let's get to it. So this was the first X-ray that was taken. It was an accidental X-ray. It was the hand of William Ronjan's wife, and that was the wedding ring on her finger. So this was the beginning of the era of an X-rays or of the X-rays. So yeah, so now that we have started our journey, the moment this was a huge discovery that was made, or rather the invention that was made, people started rampantly using and trying to figure out the different other possibilities that could be made out of X-rays, what else could be done and how else could it be used. So there was a significant usage of radiation at that time. But then people started noticing a lot of changes, a lot of complications that started occurring, which mainly came into attention of people, especially after the Hiroshima Nagasaki atomic bomb blast and other incidents like Chernobyl gas leakage and all those things, is when we got a large population to study. And that is when people started doing a lot of research into radiation and finding out that it was not something that you could rampantly use like that. It was something that we had to use in a justified manner. So this was the first person who was the first fatality who sacrificed his life against radiation because of our lack of knowledge about radiation. That was Clarence Madison Daly. And the second picture shows his hand on a radiation or an X-ray box. And it is a fluoroscopic device which had been made by Edison. And this person is Edison. And he's looking through that device on the person's hand. So the kind of injuries that occurred with radiation was these kind of injuries to the nail, the skin, the fingers. There was a lot of damage that occurred with people weren't understanding. But that is when the studies on radiation and radiation protection importance started coming up. So radiation is not something that we need to be fearing. It is something that has its own set of rules. It is something which we need to respect. If we respect its rules, it is something that we can use in a positive manner. But the moment we start not respecting its rules, or misutilizing it, that is when we need to fear it, because that is when it is going to start showing its side effects. So for being able to respect the rules, we need to know the rules. We need to know what radiation is about, and then we need to know what radiation protection is about. So basically, ionizing radiation, the radiation that we are talking about is primarily the X-ray and the gamma radiation. And these are ionizing radiations. They interact with living tissue, and either it does not cause any absorption. If so, there is no image that is generated at all, because it is directly having a thorough transmission. And if there's no absorption, there is no interaction basically. So there's going to be no radiation, scattered radiation also. The moment there is some amount of absorption that occurs, which is very important for an image formation, when the absorption occurs, accordingly, the damage also occurs. So X-ray and gamma rays have sufficient energy that can cause ejection of electrons from the atoms, which lead to ionization of atoms and which lead to biological effects. It's not just the biological effects, there are other chemical effects that occur too. So we can see that radiation is of two kinds. There's natural radiation and there's man-made radiation. What we need to know is a person who has never undergone any medical imaging or any radiology-based treatment like radiation therapy, even then they are definitely going to be exposed to radiation, because there is always an inherent amount of background radiation. And this kind of natural radiation, most of the people are not aware of, but radiation is present in the food or the drinks that we consume, in the building materials that is present, in our in the land, in the ground itself. In certain geographies, it is more so. And as a person travels or goes higher up in the air, the cosmic radiations, the terrestrial travel causes us to get more radiation. So the people who travel a lot, or even professionals who travel a lot, are more prone to getting background radiation. And so those are all the causes of background radiation. But now that is all the natural radiation. Now comes the man-made radiation. Man-made radiation is one is the medical imaging. We already know that. That is what we're using. There is medical imaging. It can be diagnostic. It can be therapeutic. And yes, of course, there is radiation that occurs because of harmful nuclear weapons, etc. So we are going to be concentrating on the diagnostic part of it rather than the therapeutic part of it. So again, this is a distribution of roughly how much is the natural and the background radiation. So, and the man-made radiation. So actually, if we look at it, the amount that is contributed by the medical imaging is less compared to the background radiation. But yes, it is significantly higher than what it was before. So now when we come down to the basics of it, we have particles like alpha particles, which are heavy particles. So these particles are incapable of traveling a long distance. So what happens is they travel a very short distance, and when they pass this short distance is when, I'll just switch on my laser. So, okay, so we know alpha particles are the ones which have a short distance of travel because they are heavier particles. So they have a smaller distance which they are going to traverse. But what happens when they traverse the shorter distances, they are approximately the size, or they are able to traverse the size of a DNA particle, and they cause more of damage to these kind of smaller structures. While the gamma rays and the X-rays are lighter particles, and so they are able to traverse longer. They do cause ionization, but less of damage as compared to the other ones. And what happens when these interactions take place? Either it undergoes complete repair, or it undergoes partial repair, or no repair at all. So if there is a repair that is occurred which is complete, then there is no hazard that is occurred. If there is a repair which is failed, completely failed, then you get cell death or degeneration. But if there is an incomplete repair that has occurred, then you get a mutation. So when you have a cell death is when you get acute effects or fetal effects that can occur, because of cell death. But when you undergo mutation is when you tend to have the teratogenic effects or carcinogenic effects. That is what happens when there is an incomplete repair of the cell and a mutation occurs. So again, these kind of things lead to stochastic and deterministic effect, which we'll be talking about further. So we just now spoke about the alpha particles and the gamma and the X-rays. So basically, linear energy transfer is the average energy that is deposited per unit length of the amount that the track that the ionizing radiation is going to traverse along the particular medium which we are talking about. So the low linear energy transfer radiations are the X-ray and gamma rays, and the damage that they cause can be reversed. So I'm going to be telling you the very basic amount that you need to understand things, and also from the exam perspective, I won't be going into too much of details of it. So basically what you need to know is X-ray and gamma rays are low linear energy transfer radiations, and the damage that is caused by them can be reversed and it can be repaired. But high linear energy transfer radiations like alpha particles or neutrons, they cause significant damage, and this damage is irreparable damage. Most often it happens to the DNA. So now, to understand about radiation, we need to understand just the X-ray interactions. So I'll be just touching upon it. I'm not going to be talking in detail because it is a topic in itself. So there are 4 types of scattering or interactions that occurs. So first is the coherent scattering, which occurs in our body in the diagnostic range of energy. And this occurs when there is a low energy photon which interacts, and when it interacts with an atom, all it does is that it gets deflected. It's a low energy X-ray photon. Sorry, this does not occur in our diagnostic range. That's a Compton. I read that as Compton when I read. I'm really sorry. So coherent is when a low energy photon just merely interacts with an atom and it gets deflected. So there is no interaction other than that occurring. A photon which was going this way suddenly just deflects and decides to go the other way because it has hit something. So there is nothing else that's happening. There's no ionization that occurs. There's only a deflection that has happened. Next, we have photoelectric absorption, which is the most important one for us because it is the one which is occurring in the diagnostic range. It is the one which is responsible for the significant image that is formed because of the absorption. It is because of this particular interaction. So what happens here is that the X-ray comes and hits an inner orbit, an electron in the inner orbit. And to compensate for this, this inner orbit electron gets freed and it goes off as a photoelectron. And the energy that is generated gets completely absorbed in this region. But now to compensate for this valence, the space that is created here, an electron from an outer shell drops in. And when it drops in, the moment it is dropping into a fill in the valence shell, another amount of energy, some amount of photons are released. And this process, and once there is a electron that has fallen from this shell to this shell, there is another electron which is further out, which falls in from there. And this process of the electrons filling in from the outer shell to the inner shell continues till this particular atom stabilizes. And for every interaction, some amount of energy is released. Some amount of photons are released. So this is a continuous cascade of process which occurs, and there is always a lesser and lesser amount of energy that is released. Then comes the Compton scattering, and what happens in Compton scattering is the energy, the incoming X-ray photon comes and dashes into an electron which is in the outer shell. So what happens is this electron gets free, it is set free, it's a Compton electron, and when it is set free, a certain amount of energy is released. And this amount of energy that is released is going out as a scattered one. So this is a scattered electron and this is a scattered photon. So this is responsible for the primary amount of scatter radiation that is occurring. So primary beam does have radiation, but we are always kind of prepared for the primary beam. But this is one of the major causes of causing a lot of scatter radiation. And this scatter radiation is what is the major contributor towards the fog in the X-ray image and also the radiation dose incurred by the people. So yes, when the person gets radiation direct dose, there's a lot of Compton scattering that occurs. So then there are other two interactions that occurs, that is pair production and photo disintegration, which are not important in our scenario. So we will be skipping that and we go to the next one. The two interactions which are very important in our diagnostic range are the photoelectric absorption and the Compton scattering. Of this, for the radiographic image, we need photoelectric interaction, and Compton effect is responsible for all the radiation and the scatter that we incur, all the radiation dose, that additional radiation dose that we incur. So again, those are the two important ones you should be knowing. Again, I'm talking about primarily them because that is what is required for the radiation part. So what happens when the exposure occurs? There's ionization. Direct action of the ionization can lead to molecular changes. There is something which is indirect ionization, where the actually ionization of the water molecules occurs and it leads to formation of free radicals, which causes chemical changes, which is an immediate action. And then further down, this free radicals again leads to molecular changes, subcellular changes, and cellular level damage. In the cellular level damage, we can see that it has either undergone a cellular transformation or cell death, which we've already seen before also. So when it is cellular transformation, maybe some amount of repair can occur, and this leads to the damage that is called as a stochastic effect. At the other end, we have the cell death, which is leads to the formation of deterministic effect. So what did we learn earlier? When you have cell death, you are having some kind of immediate acute effect that occurs, or some fetal abnormalities. These are all deterministic effects. But when you have cellular transformation because of a partial repair, it is undergoing a mutation and you end up getting carcinogenesis or a hereditary effect, and those are the stochastic effects. So we'll talk about it later, again coming further. So when we talk about the radiosensitivity, are all the organs equally radiosensitive? No. There is a lot of difference in the range that the organs can handle radiation. The most sensitive of the radiation sensitive organs are the hematopoietic system, the reproductive system, which we know of. And that possibly because bone marrow is very active in the children, maybe that is the reason that children are very radiosensitive. But at the other end of the spectrum, we have the more radio resistant organs, which is the nervous system. It is most radio resistant. So like we saw in the previous one, these are the most radiosensitive cells and these are the most radio insensitive cells. So what are the deterministic and the stochastic effects? When we say deterministic effects, you can look at this graph and we will see that there is a level that is a threshold level. Below this threshold level, you do not see anything occurring at all. And after this threshold level is when you start seeing the effects occurring and it gradually increases. So what deterministic effect means is basically that there is always a threshold dose. Below this dose, you are not going to find any effects or any problems occurring. But after this threshold dose, you start seeing a lot of problems occurring based on the threshold dose of each organ or the threshold dose of each event. Stochastic effects and the examples of the deterministic effects are skin and hair related things, eye orbital issues like hair loss. It can be temporary, it can be permanent skin injury like some kind of erythema or skin ulcers, cataracts. And when you come to stochastic effects, it is basically because of there is no threshold dose in this case. Here, what happens is when the radiation amount increases, as the radiation dose increases, the probability of you developing a particular incident or a complication is going to be higher. So this probability increases as you are exposed. So this graph is linearly just going up. There is no particular threshold dose at all. So it is like as long as you're exposed, the more is the probability that you develop this particular thing. It does not mean that you have a cutoff. The moment you have crossed this cutoff, you're going to develop a leukemia or you're going to develop a cancer. So stochastic effects mainly leads to hereditary effects and carcinogenesis. So this is primarily responsible for all the malignancies. So again, we are dealing with the same thing as subclassification. We are seeing deterministic effects predominantly has somatic complications, stochastic effects has genetic complications, and somatostochastic complications, that is carcinogenic and teratogenic effects are seen. So again, when we see as a whole body complication like acute radiation sickness, possibly after radiation therapy and all, you would see something like diarrhea, headache, fever, vague aches and pains, and even change in your blood profile. But when you look at the local abnormalities, when the dose is in a local radiation, you can see it gradually increase in its severity. It can be from temporary decrease in sperm count to permanent sterility, temporary skin erythema to ulceration, temporary hair loss to permanent hair loss. So it is a process that you can determine. Beyond this, below this, it will not occur. Beyond this, it will gradually keep increasing. So these are the threshold dose of the deterministic effects, and we can see that the threshold dose of most of the deterministic effects lies somewhere in the range of 2, most of them. And I mean, the minimum is 2. And if you look at, this is 2 grays. You look at the unit, it is gray. And at the same time, we are seeing that most of the diagnostic X-rays or the diagnostic studies that we undergo have their studies, like the most commonest study that we do is PHS, and the radiation dose of that is only 0.15 milligray. The dosage that we incur because of any of these studies is in the range of milligrays. So we can understand that this is actually way lower than our threshold dose. So just because we undergo a bit of a few repeated imaging does not mean that we are going to have a complication coming because of that. At the same time, another thing that we need to understand is that most of the deterministic effects, the ones which need a threshold dose, most of these deterministic effects we have already spoken about, already have a repair mechanism. So when we have a repair mechanism, when you have spaced out studies, you're giving the organ or that area some amount to repair itself. So inherently, we have the capability to repair ourselves. So you have to space out your studies, if it is possible, of course. But the only organ which has a cumulative action of the radiation has a cumulative action on it is the eye. It is incapable of repairing itself. So we have to be very careful about protecting the eyes. We have to be very careful to protect the lens of the person. So yeah, this is again another example. It is just showing that with various radiation doses, you can have, this is the relative risk of developing cancer, but it is not an exact particular range by which this is roughly the rates of relative risk of cancer. So yes, this is just on a lighter note. We relate a lot of radioactivity now into, with people, kids seeing a lot of superhero movies and all. We relate it to a lot of superhero powers and superpowers that we get because of radioactivity. Yeah, but there's a lot of side effects. So that was just on a lighter note. So another important thing is the units, also not the units, the quantity, the way we quantify the radiation. There is a lot of confusion about radiation quantification because there are so many terms that are used which are pretty confusing for a lot of people. So again, I'm not going to be teaching you about the units. I'm not going to be elaborating on the definitions. I'm just going to be telling you on the simple differentiation between them. So what do we mean by, I'm not talking about radioactivity, I'm talking to you primarily about radiation in our scenario. So the first term is the exposure. So when we see exposure, what do we mean by exposure? It basically means the amount of radiation that is present in the air. So when we are saying that this much exposure was there, means this much radiation was sent out, or this much radiation was there, this was the radiation dose. That exposure means this much amount of radiation, this much photons was present in the air. Now, what do we mean by absorbed dose? So the measurement for this is, we are currently supposed to be standardly using the SI unit, which is coulombs per kg for the exposure. Next is the absorbed dose. So when we say absorbed dose, as the name suggests, it means that the dose that is absorbed by a particular material. So it is literally the dose that is absorbed. So what do we, and how do we calculate it? We say it is calculated by Gray. Now, this particular absorbed dose, when we apply it to ourselves, so what do we mean by that? When it applies to human beings, we call it the equivalent dose. But the way the human body responds to every radiation is different. So there are various radiations sources, like I mentioned earlier. We have the alpha rays, the gamma rays, the X-rays. There are various types of radiations, and the way the body responds or the way it interacts with our body is in different ways, like I mentioned about the various interactions that are possible. So each radiation has a type of weighting factor. And when we multiply this absorbed dose with the radiation weighting factor, it gives us the equivalent dose. So the equivalent dose of that particular radiation that is incurred is called the equivalent dose. Now, we have got the absorbed dose. We know it's affecting the human being, but do we know how much it is affecting us? We spoke about the radiosensitivity of different organs. So we know it does not affect every single organ in the same way. Every single organ, every part has its own radiosensitivity. So every single part has a tissue weighting factor. So just like here we had the radiation weighting factor, in this we have the tissue weighting factor. So we are, for individual areas, we're going to see the tissue weighting factors, and based on that, we see how much of the absorbed dose is incurred by each particular tissue. So we multiply it with the tissue weighting factor, and you get the effective dose. So that is the basic understanding of these particular terminologies. You need to be knowing their conversions and their units also. So again, we are basically talking and interested in the equivalent dose and the effective dose. And this is what is the interaction with the body tissue. And finally, it is a measurement of the biological effect. That is what we are interested in. So again, I spoke to you just now about the weighting factor of the different radiations. So here we have different types of radiation and their weighting factors. But what is more interesting for us is we're talking about X-rays and gamma rays, and their weighting factor is 1. So it is just units, so it's easy for us to calculate. In the same way, these are the various organ systems or tissues, and these are the weighting factors of these tissues. So calculating the effective dose for each is based on multiplying this weighting factors with the absorbed dose. So that is the basic understanding of those terminologies. So again, this is the definition of the same thing, and I'm not repeating that. So now coming to the radiation protection per se. So what is the principle, the fundamental principles of radiation protection? What are those? It is justification, optimization, and application of those limits. So what do we mean by justification for exposure? You cannot tell somebody that you cannot incur radiation just because there is a damage that can occur. At the same time, you cannot rampantly make people exposed to radiation just because it is available. So you have to be able to weigh the benefits and the chances of developing any biological effects. And by weighing these things, the pros and the cons, you should be able to decide whether this person needs the particular exposure. So for that example is, supposing you have a patient who comes to your ER, it's a 67-year-old obese male with abdominal pain. Should you proceed with a CT or not? Maybe in Indian scenario, the first thing that normally occurs is a USG. But if you think of it, it's a 67-year-old male. He has more chances of having cause of pain, which are not going to be picked up in the abdomen on an ultrasound. And also, this particular male, the patient is obese. So there are all chances that we might miss out on findings. And as per the ACR appropriateness criteria, we should be going ahead with a plain CT abdomen. You might have diverticulitis, you might have renal colicky, it can be paniculitis, it can be mental infarction. So there are a varied number of causes which can be picked up on ultrasound, which cannot be. So in this particular case, it is very easy to make a judgment. We can go ahead with a plain CT abdomen. But when you think of the same scenario in a 4-year-old male child who is presented with abdominal pain, you would need to wait a bit more, because the chances of this child having an abdominal pain because of mesenteric adenitis is way much higher than you getting a cause which is not going to be picked up on an ultrasound. And this child is going to have organs and tissues which are more radiosensitive. So you would prefer to not go ahead with a CT, but rather you would want to go ahead with an ultrasound. So it's a case-to-case justification. You would have to do the justification case-to-case. And this justification normally lies at the end of the clinician who sends the case to you. It is not, as per the protocol, it is not your responsibility. It is a clinician's responsibility to do the justification prior to sending the case to you. However, in the Indian scenario, in most of the places, it happens that either the clinicians are not aware of it, or else due to lack of understanding about radiation, they do miscalculate, or not knowing all the options, they do miscalculate things. So it is always good if we step in and are able to help them justify it. Again, next step is optimization. This is very close to justification. This is where we as radiologists or the radiographers are supposed to come in. This is where our role is placed. Primarily, our role is there. It is basically optimization of the patient dose. So we have to keep it as low as reasonably applicable or achievable. So that is ALARA, as low as reasonably achievable. But when we say ALARA, or as low as reasonably achievable, what we also mean is that we have to be giving the basic amount of radiation that is required to create, to generate the image that we require for reporting. So you need that amount of radiation which is required for image creation, or an optimal image creation. At the same time, it should not exceed beyond the limits. So this kind of a weightage, because there's no particular dose limits for the patient, because of that, this kind of weightage and decision making lies on the radiologists and the radiographers. And also, many places we are able to replace a modality with another modality. For example, when we see a child, or you come across a patient who is pregnant, she's been asked to do a triphasic CT because she has a liver lesion. So you can always, and they are suspecting that it could turn out to be something sinister, you can always offer another option for them. Maybe you can, because GAD is not safe, you can still offer that, they can undergo MRI, and still there can be a lot of studies, a lot of techniques that you can use, modified techniques in MRI that would help you at least narrow down the features. So there are many things that we can work around. Or a person who needs, a child who needs a CT renal angiogram, you can offer the option of an MR renal angiogram. So there are many options which we can think of, which might be advisable in various scenarios. So those are the places where we play our role. We should help in judgment, and we should help in reducing the patient dose as much as possible. Now coming to the dose limit, which is the third part of it. But the dose limits apply only for the staff and the public. It does not apply for the patients because the patients need the amount of radiation which is required to generate the image, which of course we have to justify and keep as low as possible, but there is no dose limit per se for that. So as per the recommendations of AERB, the cumulative dose for a radiation worker has to be 100 millisieverts for a block of 5 years. But in one particular year, it should not exceed more than 30 millisieverts. And if there is a trainee can be there in a department because they need to be learning as part of their academics, as part of them doing continuing ahead in their profession. So this is permissible, but they need to be less than 6 millisieverts per year. And when it comes to public, the dose maximum dose incurred by them should be not more than 1 millisievert per year. At the same time, if there is a pregnant worker, from the moment that she has declared her pregnancy to you, from that time for the remainder of her pregnancy, her the dose limit that is suggested is 2 millisieverts for this pregnant lady from the moment that she has declared her pregnancy. So for the remainder of her pregnancy, she should not incur more than 2 millisieverts per year. So does that mean that the pregnant lady is not allowed to work in a radiation zone? Actually, that is a misconception. It does not mean that the lady cannot work in the radiology department, because if we look at it, we all work in the CT or the X-ray units, and we are all well protected by the way the equipment or the way the infrastructure has been made. So a lady who is working in the X-ray or the CT units can be permitted to continue working. It is the one where they have open fields like fluoroscopy and high dose, like fluoroscopy, C-arm, cath lab. Pregnant ladies should not be permitted to work in these kind of scenarios, but they can continue to work in the X-ray or CT. Dose limits are not applicable to medical exposure. Justification is based on case to case here. So now again, as low as reasonably achievable, how do we do that? We have 3 cardinal rules for that. That is TDS, time, distance, and shielding, all of which help us reduce the exposure or the amount of radiation that we incur. So how do you reduce the radiation exposure? First, very obvious, limit the time. The lesser the time that you spend with radiation, the lesser the amount of radiation that is incurred. Next is increasing distance, which we'll be talking. Using shielding, again, we'll be talking about it further. So radiation protection, it is for the patients, for the workers, and the public. How do we protect the patient? Again, it has some subheadings. So I already spoke about the cardinal rules. Now coming to the collimators, if we are, there is an inherent collimation that is occurring in the machine. And when we do the proper collimation, we are ensuring that the radiation is falling only in the region of interest. And these adjustable shutters help us plan our study case to case. And it prevents a wide beam of radiation occurring. So here we can see this is a narrow collimation. And here you have a wide collimation. And when you have a wide collimation, accordingly, the amount of radiation that is generated is more. Same thing here. This is another example. This is properly collimated. This is improperly collimated. And because of that, you have a large field of view and a lot of scattered radiation. So other than that, you have the aperture diaphragm or the cones, which can be used for collimation also. Further from that, we have filtration. Filtration can be inherent, and in addition to that inherent, you can have added filtration also. And what is suggested is when you have a tube potential of above 70, you should have at least a filtration of 2.5 millimeter aluminum equivalent. 50 to 70 or below that, you should have less than 1.5 is required. And so the thing that we have to be aware of is that there is an inherent filtration that is present in the machine itself, and you can have an added amount of filtration also. So what filtration does is the lower energy photons are are filtered out, and it is only the high energy X-rays which will reach the patient and which are important for the image creation. Next, the factors that we use for the image creation are the KVP, MA, and the seconds, and the distance of the patient to the source, and also the source to the film distance. So what we need to do is we need to optimally adjust it in a way that the dose to the patient is the least, or the scatter to the patient is the least. And how can we achieve this is by, one, immobilizing the patient. So when we immobilize the patient, we are avoiding any movement blur, so the chance of repetition is reduced. And also, the lesser the time that we take in acquiring an image, the faster the chances of getting a better image and preventing any movement blur. So the other thing that we need to remember is kilovolt is the one which is determining the penetration of the X-ray beam, and milliamperes is the one which determines how much amount is reaching the X-ray beam. So when we should use the most maximum amount of kVp that is permissible, because it gives you a higher penetration and more amount of the photons are passing through to the patient. So there is the amount that is scattered on the surface of the patient is less, and more amount traverses inwards and gives you a better image. So the maximum possible permissible amount of kVp should be used. So here we can see this is a high energy, high kVp, low MA. You can see it's penetrating very nicely through the patient. But here there is low energy, so a lot of it ends just on the surface or within the patient. So that is all only contributing to the radiation dose to the patient than to the image. Now, distance. The distance that is recommended, the distance of the source to the surface. When we are looking at, on a fixed radiography, the source to the surface distance should be greater than 60 centimeters. And the chest stand to the control, wherever is the control panel, should be greater than 3 meters. It can be more than that, but it has to be greater than 3 meters. On a mobile device, in a portable device, this image is wrong because there are a lot of other people standing on the side, but I couldn't find a good reference image. So in a mobile device, you have to have minimum 6 feet of different distance. And the length of the wire normally is 2 meters. So you have to make sure you call out properly, give time, adequate time for everybody to go and, cover themselves up and stay behind concrete slabs. No unwanted person should be present in the vicinity. You have to be having a lead apron, maintain minimum 6 feet distance from the device, and then shoot. And this preparation should happen. You should maintain the device, the distance way before you shoot it. So what are the methods by which you can optimize the dose to the patient? So optimizing the radiological technique by doing it properly. That is maximizing the distance between the X-ray tube and the patient. Minimum distance between the patient and the image receptor. So that is preventing fog creation, and that is preventing the amount of radiation that is required for the image creation, and limit the use of electronic magnification again, because when you do that, you are actually giving a higher dose to the patient. So, and then limit unnecessary fluoroscopic time, and whenever required, if it's not a moving structure, as much as possible, do not use a fluoroscopy for it. Whenever you want to review the images, always look at the last hold image rather than rescreening the structure again. Then do not have keep a count and tab on the number of repeats that you're doing, and use as much as possible. Reduce the collimation, keep the collimation proper, reduce the field that is covered, use pulse fluoroscopy. These are the techniques that we have already talked about. And further, for the long term, you have to get a medical physicist involved, make sure your equipment is proper. You should have regular tab on how much redos or repeat x-rays you're having. All these things that make you accountable for the amount of radiation that you're dealing with. So this is, again, correct positioning of the patient. Here you can see that this patient needs probably a hand x-ray. And if you look at it, you will get an x-ray which is correct. The image will be correct. But if you look at the positioning of the patient is directly in the primary beam. So the patient is inadvertently going to be exposed. And also the patient's lens in the face is facing towards the radiation. In this particular position, the hand is again positioned in the right way, but the patient is moved away from the radiation. So these are certain things which we are going to understand by practice, because a person who is sitting in the console maybe would not realize this difference. But if you are making a note of these kind of subtle things, you can avoid unnecessary radiation dose to the patient. Again, I spoke about immobilization. It is to ensure that you do not have to undergo more repeats. And then using shielding device, I'll be talking about it later, so not talking about it here. So this is a case where there was a proper collimation done, and this patient was given a gonadal shield. So you can see that it is correctly, there is no unnecessary exposure to the field around it. And also because the patient was given a gonadal shield, you have given appropriate collimation, and appropriate protection to the patient. So this is again kind of a repetition of the same thing, so I'm not repeating it again. Now, protecting the workers. So how do you protect the workers? So one thing is you have to work on your work culture. There has to be operational safety and equipment safety. So what do we mean by work culture? It's the cardinal rules that we have to follow. Operational safety is basically the qualified persons only should do the acquire an image, so that people with who are not qualified don't keep unnecessarily exposing themselves and the patient by taking repeated images. They have to use protective devices, and monitoring devices should be used. Equipment safety is something that the biomedical primarily looks after, and the radiation safety officer will supervise it. So we will be primarily talking about the work culture and the operational safety. So this is inherent. The lead line tube will prevent the maximum, will try to give you the maximum protection then and there itself. Unnecessary beams are mostly stopped there itself. Then coming to the cardinal rules, which we spoke about, one was the time. If you are not necessary in a particular place, then please don't be there. If you are there in a fluoroscopic unit, reduce the amount of radiation. Whenever it is unnecessary, please do not use it. That is another way you can reduce your amount of radiation. Time of exposure. Then comes the distance. For understanding distance, we have to understand the inverse square law. What the inverse square law says is that even one step taken back, whatever is the distance that you have taken back, it is inversely proportional. So double the amount of radiation is reduced for you. So actually, if you take, say, I'm just talking in the matter of steps because it's easier for us to convey. So if you take, say, 2 steps back, you have 1/4 the dense intensity of what you were incurring earlier. You take 3 steps back, 1/9, the intensity comes down. So, it keeps increasing. The intensity that is going to be of the original radiation keeps reducing the more and more you distance yourself away. So keep yourself as far away as possible from the primary source of the radiation. Then comes the shielding devices, which is the lead apron, the gonadal shield, thyroid shield, gloves, lead glasses, and the mobile lead barriers. The operator aprons are normally carrying 0.5 millimeters of lead. The fluoroscopic aprons, when it is in a device which is using up to 100 kVp, needs at least 1.5 millimeters of lead, and over 100 kVp needs 1.8 millimeters of lead at least. Gloves carries around 0.25 millimeters of lead. But the things that we need to bear in note or keep in mind at this point is that we wear these devices assuming that it gives us protection, but these things protect us only from the scattered radiation. They do not protect us from the primary radiation. So just because you are wearing a lead apron or a thyroid shield or are having your gloves on does not mean that you can stand in front of the primary beam. This does not protect you from the primary beam. This only protects you from the scattered radiation. So even if you have your gloves on, try to keep your hands away from the primary beam. And accordingly, we automatically assume that these aprons are giving us protection, but we need to ensure that these aprons are actually efficacious. For that, periodical checking of these protective devices needs to be done. They need to be screened to ensure that there's no cracks in them, because the cracks may not be evident from outside, but even a small crack is enough for the radiation to leak out and reach us. So we need to have periodical checking of these protective devices. Then other than that, we have protection in the room itself. We have protective barriers. So there is a primary protective barrier and the secondary protective barrier behind which you go and stand. So those also help us. And again, whatever said and done, we should not be in the primary source of radiation. We should not make ourselves be anywhere in the primary beam. And because we radiation workers are always prone to being exposed to radiation, we should never stand as people who are helping in restraining the patient, because by profession you are more prone to getting exposed to radiation. So the restrainer should always be a person who is the bystander of the patient and not a radiation worker, because your profession prones you to get a lot of exposure to radiation. So we should not do that. So again, this is a kind of the repetition of all those same things. We need to have our mobile protective devices also. And we should make sure that we are having some devices which are friendly to us, comfortable to us, because when we are having the lead aprons which are not very comfortable or which are not fitting us well, we try to avoid it and we try to get over it and not use it. But we need to be making sure that this is part of our radiation risk, this is part of our professional hazard, so we have to be aware of it and act accordingly. So now protection to the public. So how does that happen? Based on the room construction, the door, the signage, and attendance. So this is the basic construction which has been stipulated. So based on that, the radiation room, the room where the radiation source is, needs to have a 23 centimeter, this yellow one is the radiation wall, the wall of that room, which is supposed to be 23 centimeters thick, or at least 2 layers of brick should be there. And whenever you have there, wherever you see that the primary source is going to come and fall. So here is the chest stand, so the primary source is going to come and fall here. So here you are supposed to see what lies beyond it. If in this particular place you have a corridor, or it's just an empty space, or it's a storeroom, so you don't have a lot of people there, so then it's okay. But if you have there a place which has high occupancy, like supposing it's a place where you have a waiting room, then you need to have this wall reinforced further, because you're going to have a high occupancy in that area. So that time you need to make this at least 35 centimeters thick, or 1, 2, 3 brick layers thick. That is what is supposed to be done for the primary beam, wherever the primary beam comes. And then ideally you should have only one door, but in case you end up having 2 doors, you need to have it between 2 wooden planks, you need to have at least 2 millimeters of lead. And then, okay, the area of the room and all is stipulated. It is ideally said to be, for the radiation room, should be 18 meters square. So now, if you have a door as per the specification, that is not enough. You need to have the radiation light, which suggests that the radiation is on inside and X-ray is being taken. So you need to have the red light, or the X-ray in use sign should be there. Also, a radiation signage, warning sign, needs to be there. Another thing that we need to make sure is, when you are inside the room and you're taking an X-ray, ensure that you lock the door so that nobody inadvertently enters the room and accidentally gets exposed. So these are the things that we can do for taking care of the patients. And in case there is a public, that was not for the patients, for the public, sorry. And in case the public needs to be there as a bystander, as an attendant, then what we need to do is we need to give them appropriate radiation shielding devices. And so that was about the public. So now coming to the special scenarios, like the radiation effects on fetus. So this is something which is very important, and this is something which we need to be aware of, because it gets asked to us also, even as practicing clinicians, this gets asked to us always. So what we need to understand is that when you are exposed in the first 2 weeks of your pregnancy, the chances of miscarriage is very high. When you're getting exposed from 2 to 8 weeks of pregnancy, the chances of you, the fetus undergoing dysplasia or and developing malformations is high. In the period of 8 to 15 weeks, the fetus tends to have a high propensity of developing a lower IQ or a mental retardation. Following this period, the chances of carcinogenesis is high, probably in the later part of their childhood or adulthood. So the most concerning part in this is the 2 to 8 weeks, because that is the time when you have maximal fetal malformations that can occur, because that is the time when there is maximum organogenesis that is occurring. And that, when we already saw that when there is a rapidly developing cell present, that is supposed to be most radiosensitive. So that is why this period is very crucial for a pregnancy. And the threshold dose is 0.1 gray. More than that is not permissible during pregnancy for a fetus. So unfortunate part is, unless and until a lady has a missed period, she does not realize that she's pregnant. So 2 to 4 weeks is a period which gets missed because they are not aware that they are pregnant. But this is a question they come and ask us often. I had an accidental X-ray. What do I do further? So the next, first question is, how do they know if they are pregnant or not? So for that, we need to pick up the calendar, ask them what was the date of their LMP. But this again applies only to those ladies whose cycles are regular. For those whose cycles are not regular, there is no other way of knowing it. You have to go and undergo a urine pregnancy test or beta HCG, whatever is applicable. But if you know that the periods are regular, then you have to calculate based on the 10-day or a 28-day rule. So what the 10-day rule says is that after your periods for 10 days, it is safe to undergo a radiation imaging. But nowadays, that has got largely replaced by the 28-day rule, because it's a very restrictive rule. When we say 10-day rule, means 10 days of your cycle, you can image yourself. And for the rest of the 20 days, you cannot image yourself. So that is very restrictive. So if a lady needs an X-ray, she needs to wait 1 more month for her to get her next periods and then take an X-ray. So it's very restrictive. So what was done was it was remodified and a 28-day rule came in. So what it says is after your periods for 28 days, it is okay. You can undergo the radiation, but it has been made optional that if it's a lower level dose, then you can undergo the 28-day rule. But if you need a higher level of radiation, say you have a cath lab procedure which is elective, or you have to undergo, say, PET-CT or something like that, something which is elective and a high dose, then you follow the 10-day rule. Of course, if it's an emergency, then you go ahead with the study or do a UPT and find out. So we already read that 0.1 gray is the threshold. So yes, a threshold for fetal malformations is 0.1 gray or 100 milligray. Below this, termination is not justified, but how do you know that you are at this level? So if the mother has undergone, we can see that you have the chest PA. So the fetal dose incurred would be around less than 0.01 milligray. Abdomen or pelvis AP radiograph, and the fetus would have incurred around 1 milligray. So there are many sources like this available. This I've taken from FAST textbook, but there are many such sources available on net also, where you can get a reference range and you will be able to guide the patient further by looking at the reference ranges. And in case you need to undergo an imaging for a pregnant lady, what you do is only the area of interest needs to be exposed. Rest of the area needs to be covered properly. The abdomen needs to be shielded well. And make sure you always take an informed consent from the lady, because in the future, if something happens, you should not be held responsible for it. So always make sure you take an informed consent from them. So the next special scenario is the pediatric age group. So yeah, one size does not fit all. Just like the lead apron on them, it does not fit them. So we have to make sure that we do or optimize things optimally for them, tailor-make things for them. Just like this apron doesn't fit them, all the studies that apply to us do not apply to them. So Image Gently was a drive for that purpose. And the same principles of justifying, optimizing, shielding, and immobilization needs to be applied for them. Immobilization is more important in this particular age group because we know the kids are not going to stay still. And justifying, optimizing, shielding, just like in the other scenarios, needs to be done here, but keeping in mind that they are having hypercellular cells. And because of that, they are very radiosensitive. Cancer risk in a 4-year-old is about 3 to 5 times higher than in a 40-year-old. Keeping that in mind, we should justify and tailor-make the studies based on each particular child, their built and things like that. So next is the radiation dosimeters. There are various types available, but what it does is you cannot really check the effective dose because it cannot be measured directly. So it is actually checking the equivalent dose and then it indirectly calculates the effective dose. So we have various methods, one of them being film badge dosimeter. This is the traditional method, but it has various films and there are some filters. So based on that, you can determine how much amount of radiation you were exposed. Based on the increasing dosage, you will have an increasing blackening. It's a very simple equipment and the sensitivity is around 0.1 to 0.2. One benefit being that it has a permanent record. So even after you've read it, you can still have the record rechecked at a later time. But the disadvantages is that it is a fixed device. You cannot make it into a finger dose. You cannot use it as a finger dose measurement. And also it's not just the radiation, it is also the heat that affects these films. So that is a side effect of this film badge dosimeter. This is what we traditionally use in most of the places in India. It is a thermoluminescent dosimeter. And what is primarily the component in it is the calcium fluoride or lithium fluoride. And the principle that it uses is thermoluminescence. What is a benefit is that even after reading, the problem is that it is a bit costly to buy, but it is reusable, so it is perfectly fine because in the initial investment and then you can reuse it repeatedly. It is less susceptible to the environmental factors, and it can be used for measuring the finger dose. The sensitivity is around 0.2 millisieverts, and it can be read only once, and this cannot be used for recording the device, for recording the dose in mammography, as it can create an image in that. And the way it has to be used is it's supposed to be worn under the apron, not over the apron, which many people do, and it gives a wrong reading. So next is the optical stimulated luminescent dosimeter. Aluminum oxide is used in it. And what happens is the X-ray, once it falls on it, the material starts emitting light, which is proportional to the amount of radiation that has been created. It is a very high sensitivity, almost around 0.01 millisieverts. But and another benefit is that it does not, once you read it, the entire history is not lost. You can reread it later at a second reading also. So that is a benefit of this optical device. And the most sensitive one of them is the electronic dosimeter, which uses the silicon diode detectors, and it is sensitive up to 1 microsieverts. But these are very expensive and mostly are used as pocket devices. So this is how the radiation, the data is incorporated in these kind of detailed things. What basically is collected is the personal data of the patient, the type of dosimeter that was used, the quality of the radiation, that is which type of radiation, the equivalent dose, the cumulative dose, and since when this radiation started being recorded until when the device is being recorded, the repetitive thing is maintained. The repeat recordings are maintained in this person's data. So other important aspect which I've not touched upon but needs to be known is a radiation safety officer. They are adequately and appropriately certified, trained, and experienced. It can be a radiation worker, it can be a physicist, medical physicist, and these people are supposed to know about the radiation safety problems. They are supposed to monitor the various implementations of the radiation devices. They are supposed to monitor it and appropriately suggest any corrective actions if they find any issues. If there is any unsafe operations, they are supposed to find the root cause analysis, find a corrective measure for it. And they are supposed to verify the implementations of these corrective actions. For all these purposes, what they do in the background is they maintain records of the personals and of the equipments. Regular machine maintenance is done by them along with the biomedical team. Then personal monitoring and the protective devices need to be monitored by the radiation safety officer. The licenses renewal, all that lies in the radiation safety officer's hands, and periodic safety reports of the equipments need to be generated. Along with all this, you all need to know the guidelines as per your national regulatory agencies, because there might be small subtle changes between the various regulatory agencies, and there might be certain other policies in different areas. So you need to know your national regulatory policies also. So these are the references that I used. So again, there is a lot of things that can happen because of radiation. It has a lot of advantages, but it has a lot of disadvantages also. So whatever happens in the ending is finally going to change everything that happened in the beginning. So be judicious about how you use radiation, be judicious about how you protect yourself, how you protect your society, and how you can get the best benefits of this radiation. So thank you. Hopefully this was useful to you, and hopefully you can utilize it in your day-to-day practice too. Thank you.